Awesome. Well, like Dr. Thrasher said, my name is Lauren, and I'm one part of the perinatal program through the Institute. I work with a team of nurse practitioners, nurses, and dietitians to help bring optimal blood glucose control to our patient population. And today I'm going to talk about how we do that specifically for folks with type 2 diabetes. Now, to better understand how diabetes is impacted by pregnancy, let's just really quickly go through the hallmarks of type 2 diabetes, which you've seen a little bit of today. So we see a decreased production or decreased production of insulin, or well, there is decreased production of insulin due to beta cell dysfunction, but there's decreased insulin sensitivity, which means there's a higher insulin requirement in order to bring blood sugars down to normal or desired values. We have that beta cell dysfunction. We see metabolic dysregulation that looks like hyperglycemia, high blood pressure, hypercholesterolemia. And then we know that type 2 diabetes is already a pro-inflammatory state. So we see an increased serum levels of the necrosis factors and interleukins and CRP. And so these pathways are all exacerbated during pregnancy due to hormone changes that occur. Now, placental hormones in pregnancy are already known, even for folks who don't have pre-existing diabetes, to cause problems. So that's where gestational diabetes comes in. We see placental hormones increase the insulin resistance, and that's going to raise blood sugar levels. So for folks who already have uh, decreased insulin sensitivity, beta cell dysfunction, the placental hormones are only going to make that worse, and we're going to see a huge rise in blood sugars because of it. Now, the reason we care about blood sugar control in pregnancy is because there are lots of complications associated with high blood sugars in pregnancy. So we see an increased risk for small babies or SGA babies. We see an increased risk for large for gestational age babies. So we have two ends of the spectrum that we're trying to avoid. We see fetal abnormalities like cardiac anomalies, kidney problems, spine formation development. All of those things are at increased risk when blood sugars are high. There's increased risk for shoulder dystocia, so baby getting stuck in the birth canal. Increased risk for neonatal hypoglycemia, which looks like baby's born and they're disconnected from their sugar source. And so their blood sugar plummets, which results in a NICU stay. We see preterm delivery and sometimes fetal demise. And then in the long term for baby, there is a risk for elevated BMI in baby's teen years, which has a concern for what other metabolic issues will occur later in that child's life. So the good news is, with all of those um, issues that can arise, if blood sugars are well controlled, the risk of those things decreases. So what our team does is we come in and we follow with our patients every 1 to 2 weeks, sometimes 4 weeks, sometimes three, depending on the person, right? Depending on what's going on in their situation. We work with them hand in hand to get as tight glucose control as we possibly can. Now, what that is going to look like is fasting blood sugars of less than 90, which I know for a lot of people is really scary because for some people that's where their lows start. So we work hand in hand with patients to kind of slowly bring those down. We have a target postprandial value of 120 at the 2 hour mark and 140 at the 1 hour mark. We don't make patients check at the 2 and 1 hour. Our goal is to just get one of those values after each meal. And then we do this to hopefully get that A1C underneath 6 as quickly as we can. Ideally, for somebody with pre-existing type 2 diabetes, we would have already been meeting with them. We would have already been working on them or working with them to get their blood sugar underneath that A1C value of 6. That is because there is an increased risk for these complications or for those complications that I mentioned, with an A1C above 6. And so we really want to steer clear of that and get underneath that target of 6 as soon as we can. Now, there is one complication that has a tighter, that requires tighter glucose control, and that's for large babies. So there have been studies that have shown that sometimes you can get underneath that target of 6 and still have an LGA baby or a large baby. So we have to work a little bit harder to get that A1C underneath 5.7 as well. So, how do we do that? Well, we have them monitor their blood sugar a lot. So it looks like checking blood sugars 6+ times daily, which is a lot of finger sticks, or we can just use a CGM. And so we do like to use CGMs quite a bit. I'm going to talk about that here in a second. But it's really important to note that the prevalence of type 2 diabetes in pregnancy has more than doubled since 1990. So that is a wonderful thing, but also a very concerning thing. It's wonderful in the sense that um, people feel empowered to get pregnant and have children. It's a scary thing in the sense that all of these complications need to be navigated for a much larger number of people. So, continuous glucose monitors. We love them. I've listed just a few of them on this slide. There's several others out there. The ones that we see most often are going to be the Dexcom, Freestyle Libre, and the Guardian. We love them because they provide, as providers, we love them because they give us great insight in blood glucose control. We get readings every 1 to 5 minutes. It also helps patients a lot because they can see what's actively going on with their blood sugars, and it helps decrease the number of finger sticks required by them. I've never had a patient complain about not having to do as many finger sticks. So they love that. We get the glucose report, which is really helpful in figuring out what medication changes or figure out what areas of intervention are needed for our patients. And then one other aspect that we love is that it can communicate with pumps, making it easier for our patients to bolus for things like carb ratios and corrections. But I'm going to talk more about pumps here in just a minute. So before we get to pumps and insulin and all that fun stuff, we're going to talk about how we really do, or I'm going to talk about how we really optimize blood glucose control for our patients. And it's not as simple as we just get to come in and tell them what they're going to do. We don't get to just come in and say, you get to be on 10 units of long acting, you get to be on short acting once with meals. There is a component of that, but we have to make sure that we are acknowledging what the patient wants, what they're able to do, what ability do they have. And then, of course, the clinical experience comes in at that point. So at the intersection of those three things is that's really where we practice. We want to honor what the patient wants. We want to recognize their understanding and their ability and what they have the capacity to do. And then, of course, we want to come in with our clinical expertise to help smooth things out. So there are two primary areas of intervention. The first being nutrition. And nutrition intervention for diabetes and pregnancy is not as simple as just carbs. Of course, it's a complete picture. We need to get adequate protein intake first and foremost with those patients. We need to make sure that if they aren't getting adequate protein, that they start, because if they don't have that, then it's going to be really hard to control their blood sugars because, as we know, protein helps stabilize blood sugars. So we want to make sure that they do that. Now, the protein requirement in pregnancy is about 1.1 grams per kilogram. That can be quite a bit of protein, so it takes a little bit of finesse sometimes and nuance to get patients to those targets. Then we also want to make sure they're getting adequate non-starchy vegetable intake. Now, that's the reason for that is twofold. One, there's tons of micronutrients in those vegetables that are going to help mom and baby be as healthy as possible. And so we want to make sure they have access to that and that they are getting that in their diet. Secondly, it's going to help with their fiber intake, which is just going to help with blood glucose control, of course, because we know fiber helps with that. but also with just keeping moms regular and just helping them feel better and help make their pregnancy a little less stagnant in that regard. And of course, we have carbohydrates. Carbohydrates are very important to managing diabetes and pregnancy, and diabetes in general. Now, the tough thing about pregnancy is there is a standard out there that says every mom should get a minimum of 175 grams of carbs per day. And the reality of it in practice is that's not always the best situation for mom. So we use about 160 or 175 grams of carbs in their diet as a springboard, but there will be some people who can tolerate more than that, and that's great, and we will support them with that. But there are some people who struggle to tolerate that at all. There are some people who will struggle to tolerate 45 grams of carbs per meal, and so we want to honor that as well. And if they want to make dietary changes that are healthy and that decrease the carb amount, that's okay. We're going to help them in that. Um, but we're never going to support somebody going full keto. We want them to have a moderate carbohydrate diet, not like a very low or low carb diet. So we work with them. We walk with them through that and make sure that they're staying healthy, their baby's staying healthy, they're getting enough carb in, and we help them get to their goals. Now, I will say that typically what's recommended is 30 grams of carbs at breakfast, 45 at lunch, 60 with dinner, 15 with snacks just periodically throughout the day. We usually like to start people on 30 grams of breakfast, 45 lunch, 45 dinner, 15 grams of carb snack. That's just a starting point. Because we've seen a lot of folks just do not tolerate 60 grams of carbs at dinner, whether that's a whether that's because they've slowed down for the day and they're not moving around as much, or their bodies are just struggling to process that 60 gram of carbs. But that's pretty typical to see for us. But truthfully, there are times where you can make as much nutrition intervention as possible, and it just doesn't get you where you need to be. So that's where we use medications. Now, there are two pathways for medical interventions in pregnancy. One is oral agents, things like metformin and glyburide, and then you have insulin. So insulin is the gold standard, and we're going to talk about that in a second. The reason we love insulin is because it doesn't cross the placenta. The oral agents, metformin and glyburide, do cross the placenta, which is where we kind of get into murky water with them. So first, let's talk about metformin. Metformin, it's really not recommended for use in pregnancy anymore, but sometimes we do see people come into pregnancy on it, and we'll keep them on it sometimes. But a lot of times at the end of that first trimester, they're coming off of it and they're transitioning to insulin if they're not already on it. Now, metformin can cause issues for baby. It can cause risk of small babies, small for gestational age babies. It can also decrease the fetal kidney maturation, and so we don't want babies' kidneys to be impacted. And then there's a higher risk for moms who are solely on metformin, or for babies of moms solely on metformin, that that baby will end up with obesity in adulthood. So what the studies have shown is that moms that are solely on metformin, because I said that weird, moms solely on metformin have children. When those children grow up, they tend to have higher rates of obesity. And so that's a concern, of course, for their development of type 2 diabetes, potentially their risk of development, and so on. Now, there are some benefits to metformin use in pregnancy. One is it decreases the risk of large babies, and it helps decrease maternal weight gain. So there are some benefits to it, but the risks most of the time are going to outweigh that. And so we don't prefer to use metformin if we don't have to. Then there's glyburide. Glyburide is a secretagogue, which just forces your pancreas to produce insulin in a pretty unregulated fashion. We do not like the use of glyburide at all unless it's absolutely necessary. And I can't think of a situation here where we would see that, where glyburide was necessary. because we actually have pretty good Medicare, Medicaid coverage or Medicaid coverage of insulin. But um, glyburide comes with higher risks of hypoglycemia, so we don't get good glucose control. Because if somebody's dropping all the time, that's not good control of blood sugars, right? We do want to avoid that. It also stresses out the mom's pancreas and baby's pancreas because it crosses the placenta, and that's not a good thing. So when we think about type 2 diabetes and how it functions and how it works, and we already have that beta cell dysfunction, we don't want to stress the pancreas out further, and we don't want baby's pancreas getting stressed out further because that's going to increase risk for baby to go on to develop type 2 diabetes in their lifetime as well. So, going back to insulin, we love it. It is gold standard. It doesn't cross the placenta. So really, it helps to keep blood sugars regulated without concern for baby because it can't touch baby because it cannot cross the placenta. I cannot stress that enough. Typically, what this looks like is a combination of short and long acting insulins. Sometimes it's just as simple as one shot of long acting insulin a night for a patient. Sometimes it gets as complicated and complex as 6+ shots a day, three of long acting, 3+ of short acting. When that occurs, we really like to go ahead and start the use of a pump because it's going to make mom's life easier. It's going to help them get the optimal blood glucose levels for that pregnancy. So, sometimes we even have to use concentrated insulin in the pumps, which is technically an off-label use, but it's the reality that we live in because these patients become so insulin resistant that the insulin requirement is just through the roof. So sort of to pause here and switch gears for just a second, for a patient with type 1 diabetes, so doesn't necessarily have underlying insulin resistance going on from the start of pregnancy, there is a 70% increase in their insulin needs alone just from pregnancy. So you can imagine that if someone already has underlying um, insulin resistance, underlying beta cell dysfunction, that is going to be a lot. That percentage is going to be higher for them because it's just amplified, magnified. Those hormones are just really pushing mom's body as far as they can. So, all of that being said, sometimes we have to use concentrated insulin and insulin pumps. We also, when we do use insulin pumps, we don't let them run in auto mode the majority of the time because there are, of course, circumstances where um, that would be necessary. But the majority of the time, we're running it in manual mode because pumps don't allow blood sugars to get low enough and in those target ranges. We really want, when we're looking at a continuous glucose monitor, the report, we want that average blood sugar to be right around 100. And most pumps are not going to allow, auto mode in most pumps is not going to allow that to occur. So what we end up doing is getting people on insulin pumps, and then we transition them to manual mode, and we make changes to the pump as regularly as necessary. So, or as routinely as necessary. So, for somebody that might look like one change a week, one small change. For somebody else, that might look like we're doing one change every 2 days to try to get that blood sugar in tight, tight control. Now, the good thing is, well, I guess it's not good yet. We don't know, but there are some promising changes coming up with pump algorithms, some encouraging things, some lower target blood glucose values that might allow for some pumps to run in auto mode, but time will tell. We will see. We'll see what happens. Now, I did want to touch on supplements in pregnancy. Um, Technically, there aren't a lot, or there's not a standard for supplementation in pregnancy, but I wanted to talk about it today because it's very important for people with type 2 diabetes to have kind of like a leg up. Like sometimes they need a little assistance with what's going on nutritionally. So, of course, we're going to recommend a prenatal with iron. If someone does not have adequate iron and isn't just getting their bases covered with that prenatal, um, you know, there's concern for what gaps are lying there. But also with the iron, if they don't get enough iron, the A1C is not going to be accurately reflected. If someone has low iron status, they're going to be, or if they're anemic, they're going to have a lower A1C. The A1C is going to reflect lower than it actually is. And so there's concern that, oh, we could think we're at target. Mom's A1C is 5.8, 5.8, and that's not the case because the iron status is off. Then we have vitamin D. Vitamin D helps decrease inflammation. So, like we talked about at the very beginning, type 2 diabetes is already a pro-inflammatory state. If mom comes into pregnancy with low vitamin D status, um, there are um, concerns that their blood sugars will increase a lot faster. So we see with women who come into pregnancy and vitamin D is low, once that's fixed and it's up to above 30, um, fasting blood glucose is like to even back out. So we get a good lower fasting blood sugar. So that's really important. Then there's methylfolate, which has actually been a really hot topic lately, if you know anything about supplements. So it is the active form of folic acid. Now it helps to regulate, in type 2 diabetes, it helps to regulate the level of serum homocysteine, which is directly related to some of that inflammation. Um, for somebody with diabetes, the higher the level of homocysteine, the higher the risk of retinopathy and neuropathy. And so for somebody who's pregnant, we want to make sure that that risk stays low, right? And then also for baby, we want to make sure there's adequate choline intake for their just brain and neurological development. One thing I did not put on here, but that is also a hot topic, is probiotic use in pregnancy. There's basically no studies on probiotic use in pregnancy, but we know that for people living with type 2 diabetes, probiotics can be beneficial. And so that might just be an area to look at in the future. Um, but time will tell, and we'll see what happens. Any questions?
Lauren, thank you for your lovely presentation. And yes, you have several questions. So let me get started here. So the first question is, will insurance cover CGM use in pregnancy regardless of insulin, or is insulin use a requirement?
Yeah, so a lot of times insulin reuse is required. So usually I will say there are more frequently, we're seeing CGMs covered just in pregnancy without insulin. Now, with somebody who has type 2 diabetes, the standard out there is for them to just be on a CGM. Like that is the ADA standard. Some insurances have not caught up with that yet. Most of the time, we're going to be able to get it covered for somebody living with type 2 in pregnancy. Um, Sometimes it's going to require that use of insulin, and I will say I'm going to add this in as well. So it's a gray area. We're going to get it covered at some point, um, most of the time. Um, but some insurances really just won't cover it until you're on insulin. Now, most people who have type 2 diabetes are not going to go very long without being on insulin. I think I can calculate or I can estimate, like, I can probably count on one hand the number of folks with type 2 diabetes who have not needed insulin during pregnancy. Um, yeah, that's just a tangent though.
Perfect. Well, next question. It's how can we assist the patient while inpatient? Because this person has realized that when the patient is hospitalized, it's much harder to control blood sugars because we don't feed them the same diet that they usually eat at home.
Yeah, yeah, that's always a fun one to navigate. Sometimes we're hesitant to send people over to the hospital because it's like, man, their diet is so controlled. They're not eating the same. Blood sugars will look great in the hospital. And then they come home and it's like crazy. So we actually have an inpatient educator who goes inpatient. That's her whole job. And to provide education for folks to learn how to do that diet control, learn how to count those carbohydrates. Inpatient wise, I mean, it's really hard to say let them eat whatever they want because ideally, um, it's going to be a lot harder to get that control in the hospital with if they're if we send them or if they are sent with the goal of glucose optimization. It's going to be best to get a baseline improvement to blood sugars. So there's not a lot as far as like diet wise they can do in the hospital. It's just going to be let's get them settled, let's get things improved in the hospital, and then they'll come back out to us and we'll start working on that like real life diet, carb counting aspect, find out the areas that they're struggling with. So it's really, it takes a whole team. It takes a whole team
Yeah.
to get effective and optimal blood glucose control. On the inpatient side, there's not a whole lot of like if they don't eat that way, they don't eat that way. You know, it's just the reality of it. So it's getting good control when they do have a carb steady diet, when they do have a moderate carb intake, and then flipping them back to us on the outpatient side, and we'll further finesse it.
Got it. Perfect. Well, how about for patients who follow a whole food plant-based nutrition plan? Do you recommend any changes during pregnancy?
So if you're going off of the standard of whole food plant-based like vegan diet,
Hmm.
it's really hard. So it's really, really hard to get all of the fat that you need, all of the protein that you need with a whole food plant-based diet, if that's what you're talking about. So we have worked with patients in the past who follow strict vegan or super strict vegetarian diets. It's really tough. Sometimes it's even like the fact that they're not getting that adequate protein impacts the severity of their blood sugars. And so a lot of times it can look like adding in a protein supplement. It can look like having a discussion with the patient about, hey, would you be willing to try eggs? Would you be willing to add in some dairy products? Sometimes the answer is yes, sometimes the answer is no. But there is pretty strong research that suggests it's not ideal to follow like whole food plant-based diet in pregnancy. Does that mean that if somebody follows that, they're going to have a poor outcome? No, that's not what that means. But there are gaps in the nutrition there that are concerning.
Got it. Okay. How do you handle adjusting pump settings post-pregnancy if there's a sudden change in insulin needs after delivery? Do you have a follow-up workflow?
Yep, we sure do. So typically we see people 2 weeks postpartum, somewhere usually between 1 to 2 weeks postpartum, and then we are going to hand them over to their either endocrinologist or if they have a pump, they should be with an endocrinologist. So we follow with them until they see that endocrinologist. Now it's not going to be the same every 1 to 2 weeks like we were doing when they were pregnant because their blood sugars should level out, but we're going to be their point of contact on that until they get back in to see their endo. Now, when someone delivers a baby, automatically we go ahead and have them reduce their pump settings by 50% of what it was at the very end of pregnancy to help kind of offset that decline of those placental hormones that are going to not be there. They're not going to be there anymore to mess with blood sugars. So we go ahead and cut it to 50%. And then while inpatient, there's some titration that occurs down to what is a safe level for mom.
Cool. Thank you. Last question. Are there any community resources you can recommend?
Well, community resources as far as like
Uh,
information or just like for insulin.
it's a great question.
Okay. Well, let
I
me
don't
try
know
to,
where we're
I'll,
going. Just yeah, community resources is kind of the statement that was asked.
okay. So you can get online and you can find, if you look up the ADA resources. Those are really good. So the American Diabetes Association. There's not a ton out there that I would recommend necessarily for type 2 diabetes and pregnancy because it is such an individualized state. So if we're talking about resources like that, you can look up some things. Um, I don't know what that question is specifically, but community
Okay.
resources. Oh, go ahead.
No, another question just came in as well, and it was what about the recommendations for breastfeeding mothers as far as nutrition with diabetes and management of blood sugars?
Yeah. So a lot of moms will see low blood sugars happen when they breastfeed. So depends on the person, right? Again, everybody's different. So for most folks, they're going to see a decline in their blood sugars when breastfeeding. So it's important to have a snack. It's important to stay hydrated. Some people will even have to pause their pump for a little bit, which I know is controversial, and a lot of people are like, "Oh gosh, don't do that." Um, if you pause it for a minute because you're about to be 40, it's going to be okay. Um, you're not gonna, it's not gonna rebound super high if you turn it back on. Um, but that can be an important thing to do, and it's really important to navigate it, especially for moms that are breastfeeding. So snacking is important, and I don't mean snacking like, you know, you're eating a huge high carb thing, but like a handful of nuts while breastfeeding can go a long way for those moms.
Perfect. Well, Lauren, again, thank you so much. Lovely talk. A lot of engagement there. So thanks again for your time. And we're going to move on to Mikala Perez. She's going to be talking, her title is It's Not the Carbs, Nutrition Strategies for Type 2 Diabetes.